Hello everyone, and welcome back. Today we'll discuss hypercalcemia, a common electrolyte disorder that ranges from an incidental laboratory finding to a life-threatening emergency. By the end of this video, you will be able to understand calcium physiology, classify the severity of hypercalcemia, develop a systematic diagnostic approach, recognize common causes, and manage hypercalcemia based on severity and etiology. Let's get started. Remember that serum calcium exists in three forms: 45% ionized calcium, the biologically active form; 40% protein-bound, mainly to albumin; and 15% complexed with phosphate and citrate. Normal total calcium is approximately 8.5 to 10.5 milligrams per dl or 2.1 to 2.6 millimoles per liter. Since albumin affects total calcium, always correct the calcium when albumin is abnormal. Corrected calcium in mg per dl equals measured calcium plus 0.8 times for minus serum albumin. Or better still, whenever possible, measure ionized calcium, especially in critically ill patients. Hypercalcemia is generally classified as mild, 10.5 to 12 milligrams per dl, moderate, 12 to 14 milligrams per dl, and severe, above 14 milligrams per dl. Symptoms depend on both the calcium level and how rapidly it rises. A useful mnemonic is stones, bones, groans, thrones, and psychiatric overtones. Patients may develop renal manifestations like polyuria, polydipsia, nephrolithiasis, and acute kidney injury. Gastrointestinal symptoms like nausea, vomiting, constipation, and pancreatitis. Neurological manifestations such as fatigue, weakness, confusion, delirium, and coma. Cardiovascular, hypertension, bradycardia, shortened QT interval, and occasionally arrhythmias. The first question after confirming hypercalcemia is the PTH elevated or suppressed? This single test directs the diagnostic workup. PTH elevated or PTH-dependent hypercalcemia. The most common causes include primary hyperparathyroidism, tertiary hyperparathyroidism, familial hypocalciuric hypercalcemia, and lithium therapy. Remember, primary hyperparathyroidism and malignancy together account for more than 90% of hypercalcemia cases. PTH suppressed or PTH-independent hypercalcemia. Common causes include malignancy. Examples are PTH-related peptide secretion, osteolytic bone metastases, multiple myeloma, and lymphoma. Vitamin D-related. Vitamin D intoxication and granulomatous diseases like sarcoidosis and tuberculosis. Endocrine disorders, for example, thyrotoxicosis and adrenal insufficiency. Medications like thiazide diuretics, vitamin A excess, calcium supplements causing milk alkali syndrome. Other causes are immobilization, Paget disease with prolonged bed rest, and recovery phase after rhabdomyolysis. A practical algorithm is very simple. First, confirm true hypercalcemia. Repeat calcium, correct for albumin, and measure ionized calcium if needed. Second, measure intact PTH. If elevated, think primary hyperparathyroidism. If suppressed, proceed with PTH-related peptide, 25-hydroxyvitamin D, 1, 25-dihydroxyvitamin D, serum and urine protein electrophoresis, TSH, cortisol when adrenal insufficiency is suspected. Additional investigations may include chest X-ray or CT, CT abdomen, bone imaging, PET scan when malignancy is suspected. Treatment depends on both severity and symptoms. Mild asymptomatic hypercalcemia often requires oral hydration, stop offending drugs, treat underlying disease, and close follow-up. Moderate to severe hypercalcemia. This is a medical emergency if symptomatic. First, aggressive intravenous hydration. Use normal saline. Most patients are volume depleted due to nephrogenic diabetes insipidus. Aim for adequate urine output while avoiding fluid overload. Second, calcitonin. Calcitonin lowers calcium rapidly. Onset, 4 to 6 hours. Effect lasts about 48 hours because tachyphylaxis develops. Think of calcitonin as the bridge therapy while waiting for bisphosphonates. Third, bisphosphonates. Examples include zoledronic acid, pamidronate. These inhibit osteoclast activity. Onset is slower, typically 2 to 4 days, but the effect is sustained. Number 4, denosumab. Particularly useful in bisphosphonate-resistant hypercalcemia, severe renal impairment, and malignancy-associated hypercalcemia. Fifth, glucocorticoids. Effective for vitamin D intoxication, sarcoidosis, and lymphoma. They reduce intestinal calcium absorption and decrease vitamin D activation. Sixth, dialysis. Hemodialysis should be considered in patients with severe hypercalcemia with renal failure, fluid overload, and heart failure limiting hydration, refractory hypercalcemia, and life-threatening neurological manifestations. Here are 5 important take-home messages. Always confirm true hypercalcemia before initiating extensive investigations. PTH is the single most important first diagnostic test. Malignancy and primary hyperparathyroidism account for over 90% of cases. Hydration is the cornerstone of acute management. Calcitonin works rapidly, while bisphosphonates provide sustained calcium reduction. Hypercalcemia is a common but potentially life-threatening electrolyte disorder. A structured approach based on confirming the diagnosis, measuring PTH, identifying the underlying cause, and initiating appropriate therapy allows rapid and effective management. In critically ill patients, early recognition and prompt treatment can significantly improve outcomes. Thank you for watching. If you found this video helpful, please like, share, and subscribe for more evidence-based videos on critical and acute care for doctors. I'll see you in the next video.